further ado, Doyin, it's off to you.
Sure. So thank you, Jennifer. And hi, everyone. So my name is Doyin Sonibar. I know some of you are colleagues and some of you are students that I've worked with, and some of you are current students at Queen Mary University of London as well. So I just finished my master's degree in global public health, and my dissertation was on sickle cell disease. So today I'm just going to be talking a bit about some of the content, some of the research that I carried out, and just my overall process. I'd really like to make this as interactive as possible. So if anyone's got any questions on anything that I'm saying, please feel free to interrupt. This is not a formal presentation, and I have as much to learn from you as you have to learn from me. So yeah, so I'll get started. So essentially, my dissertation title was The Effectiveness of Care and Pain Management During a Sickle Cell Crisis. And it was a scoping review focusing on the perception of Black sickle cell patients. So before I go into my full presentation, I would really like, and I'm gonna just see if I can stop sharing, because I would like to find out what everyone on this call understands about sickle cell disease. So bear with me quickly. I just want to see if everyone can see my screen now.
I think you've stopped sharing it.
Yeah, because I want to share something else.
Oh, great.
It's intentional. Okay, can everyone see my screen?
Yep.
Okay, perfect. So if everyone could go to www.menti.com and use the code and just describe sickle cell disease using 3 words. It's just, I think it'd be really good to understand what everyone thinks about sickle cell disease in the call. I'll give you guys a minute.
Sorry, Doyin, what's the code?
2373324. Interesting. I'm not too sure who's writing it out in handwriting. I didn't know you could do that on Mentimeter, but I can't read it, I'm sorry. If you could type it, it'll be easier. Okay, I know we've got a few more people in the call, so if you could please hurry up, guys, and just input some more, that would be really, really, really good. Okay. Okay, cool. So we've got at least 10 responses. So the biggest one here is anemia, got painful, life-changing, Black community, hemoglobin, reducing oxygen, hereditary, excuse me, difficult, interesting word, serious, mutation. Okay. So it does sound to me that everyone already has a good understanding then, or at least some sort of idea as to what sickle cell disease is about. Oh, we've got a few more. Okay, disorder, Red blood cells, yes. It's all about the red blood cells. Concave, okay, great. So I'm just gonna go back quickly and share my presentation again. But thank you all for giving some insight as to what your understanding of sickle cell disease is so far. That is useful. Where are we? Okay, back to the presentation. Okay. So what is sickle cell disease? So sickle cell disease is a hereditary disorder, and it affects the red blood cells in a person's body. So I don't know if you remember, but in my original slides, I'll go back to it here, you can see that the red blood cells are circular shaped, but sickle cell blood cells are shaped like a crescent. So like a sickle essentially, and that's where the term was coined from. And essentially it's something that's passed on from parents. So if you can see in the diagram, in order for someone to have sickle cell disease, both parents have to be carriers, and they both have to have what we call sickle cell trait. And it's to do with the hemoglobin molecule in the blood. And essentially it's a disease that's quite prevalent in the African Caribbean community. So as some of you mentioned on the call, a lot of you mentioned Black community, because yeah, there's quite a few people that perhaps have had family members or loved ones who've experienced sickle cell disease. But interestingly enough, it also does affect other populations. So Hispanic people, Asian people, even white people in the UK also have sickle cell disease. It's just not as common. And it actually affects 0.02% of the British population, which sounds quite small, but if you understand the implications of the disease and how much it affects someone's lifestyle, then we can say that actually it doesn't matter that it only affects such a small percentage of the population, because it can be quite serious. And it can, I guess, kick off what we call a sickle cell crisis. And I'll talk a bit about that later, but essentially, it is an inherited blood disorder. So the history of sickle cell disease. So it actually came about and is prevalent in what we call malaria endemic populations. So areas in Africa, Mediterranean, basically in the hot tropical countries where mosquitoes are in abundance. And it initially was a biological thing. So it essentially was nature's way of protecting people from a specific type of malaria called falciparum malaria. But then due to sort of genetics and evolution, then it then became sickle cell disease. And it actually, instead of just fighting off malaria, I guess made it difficult for the body to respond to other diseases and to other illnesses. And so it made those people more vulnerable. So it's kind of an evolution of something that was originally meant to be a good thing to have because it was meant to protect you from malaria. And the guy in the really small hexagon there is a guy called Dr. James Herrick. And he found it in 1910. So he was actually looking at a student. So a young Grenadian man called Walter Clement Knoll came to him and he was complaining about issues in his leg and how he was always ill and feeling weak. And he was describing all the symptoms of sickle cell disease, but at the time, it hadn't been recorded. Now, I say he was the first one to record it in 1910, but history has shown that various tribes in Africa have dated it back to like the 17th century, where they said family members have had it. But again, perhaps due to them not having education or having shared it with other people across the world, they've perhaps thought it was a curse of some sort. But there has been stories that have been written in the past before 1910 that have shown cases of sickle cell disease across the world. So what is a sickle cell crisis? So sickle cell crisis is basically when, as I mentioned before, and as you can kind of see in the diagram there, all the blood cells are shaped like a C, like a crescent. And what that means is it prevents the blood from carrying oxygen around the body. And so what happens is you get the process of sickling when all of these crescent-shaped sickle cells get stuck in a particular area, and it restricts the blood flow. And that's dangerous because then it prevents the vital tissues and organs in the body from having access to oxygen and the nutrients it needs. And so the brain then sends a signal to the brain, sorry, not the brain, the body then sends a signal to the brain, basically say that there's a problem here. And that causes what we call chronic pain. And so that's why a sickle cell crisis can occur in any part of the body, because essentially what it is all of these cells that have kind of come together and been stuck together, it's causing a blockage of a flow of oxygen-rich blood in the body. And so the pain can be quite severe, very serious, and needs to sort of be attended to immediately. In fact, a sickle cell crisis is most always usually categorized as an emergency. And what that means is that essentially you need to call the ambulance straight away. They need to be adhered to. In fact, the NICE guidelines, which is the National Institute of Care and Excellence, stated in 2012 that every sickle cell patient should go straight into an ambulance. They should be meted by emergency healthcare professionals. They should be adhered to within 30 minutes, and they should be reassessed constantly every 30 minutes to ensure that they're okay. And essentially what that is checking their pain levels, providing them with strong opioids and medication, because the pain that they experience isn't what I guess the average person would experience. It can be quite severe. And you'll see later when I share some quotes of Black patients who have spoken about their experiences with sickle cell pain during the crisis as well. I've noticed I've spoken quite a bit, so does anyone have any questions so far? I'm happy to go on, but again, as I said, I really want this to be an interactive discussion. No? Okay. That means you guys are not getting bored of me yet, which is great. So the next thing I really want to talk about then is cure, treatment and management of sickle cell disease. So currently there isn't really a cure for sickle cell, but there is this thing called HSTC, which is it stands for hemostopic stem cell transplantation. And it's actually also used in cancer patients. So essentially what it is you take cells from a donor's body, stem cells, and then you sort of remove the host body cells, and then you then input the donor's body cells. So it's almost like taking out your cells, the bad cells, and then taking in the donor cells, and hoping that the body will accept that and that it reproduces. But that can be quite dangerous because you can get what you call graft versus host disease, where the body may reject it. And so it's not something that is always recommended to patients. In fact, it's only usually recommended to patients who are under the age of 18, so usually pediatric patients. And it's too dangerous for adults. So usually if you have sickle cell in your adult life, then you generally just have to manage it. You don't really get to unfortunately cure yourself of sickle cell disease. And in terms of management of the disease, there's various things that can be done. So as I mentioned, strong opioids are also given to patients like morphine to help them during a crisis period. Also, due to the fact that a lot of the blood cells replicate and become sickle cells, and like I mentioned before, the crescent-shaped cells, usually every 4 to 8 weeks, patients will have to have a blood transfusion. And this is why it's so important for people to donate blood, because there are people like patients with sickle cell disease who rely on the donations of blood in order to live. And essentially it's because they need the whole blood, well, the whole red blood cells that you and I have if we don't have sickle cell disease. And they need that in their bodies to help them stay healthy, help them stay fit, help them fight off these diseases. So yeah, really, really important for everyone to donate blood if they can. I know everyone has different views on that. But I would definitely recommend people do research around it and see how they can give blood. And then the following thing on that then around the treatment as well is, management, is taking into consideration their everyday lifestyle. So they have to be careful as to not to exert too much pressure, because what you don't want is to do something that can kickstart a crisis. And it can be a range of things. It can be anaerobic exercise, because remember we spoke about the fact that someone in a sickle cell crisis is already experiencing a restriction in the flow of oxygen-rich blood. So when you're performing anaerobic exercise, your body's already receiving less blood, and then you have sickle cell-shaped cells, right? So you have to be careful. Also things like flying, for example. So I know, like, one of my good friends, that when she flies, she has to carry a oxygen canister with her. And that's because, again, when you're flying at high altitude, the level of oxygens are low, and just to prevent a sickle cell crisis from occurring. Also things like the weather as well. So when it's cold, just ensuring that you're keeping yourself warm. These are the sort of things that people with sickle cell disease need to think of on a regular basis to help them manage their disease throughout their lifetime. Sorry, Ellie, you're off mute. Did you want to say something? Okay, I'm assuming she doesn't. Okay, so I just want to pause there because I thought it'd be really interesting to check and see how many people donate blood from the Black community. And I just thought I would check to see whether you guys knew what the percentages were around that. So I'm going to quickly share my screen again, and you should see another Menti. Okay, so my question for you all is, what is the percentage of Black blood donors in the UK out of all the blood donors? And again, I'll give you a minute to respond to that. Okay, 10 more seconds. There's quite a few of you in the call. Don't be shy. I can't see what what you put in, so I'm not judging any of you at all. Okay. Okay, interesting. So nobody has picked 7%.
Just let you know, there's a few in the chat as well.
Oh, do people? Because I don't actually, when I'm sharing my screen, I can't actually see what people put in the chat.
There are several votes for 3%, 2 for 3%, and 1 for 8%.
Okay. Well, the correct answer actually is 1%, which is incredibly low, unfortunately. So yeah, about 11,400 people from the Black community donate blood in the UK. And the NHS have already mentioned that they need at least 3 times that amount in order to meet the demand. So there's already a deficit. So I know different people, due to beliefs and perhaps some religious views, may not feel comfortable with donating blood, but I would just recommend everyone to do that education and that research from themselves, because as I mentioned, people's lives are immensely affected by it.
So, Doyin, can I just ask? It's Ruben here. So the question here was, so of all the people donating blood in the UK, how many of them are Black? Is that the question?
Yes.
And so how many of the total population of the UK, I guess that's also quite interesting to know, of people in the UK are Black? Do you know that? So I mean, is it like a lot less than the total percentage, or not?
So oh, go on, Karen.
Say, as far as we know, the last census taken in the UK, 3% of the population, around about the 3% mark, are identify themselves as Black.
Fair enough. Okay, yeah. So I guess it's like, yeah, it's disproportionately lower as well. Yeah. Okay,
Yeah.
cool. No, I was just curious. Yeah.
No, that's fine. Thank you for asking. Okay, so I'll go back to share my presentation again. Okay, so I promised Jen that I'd also spoke a little bit about my research and how I carried it out. So essentially, these were the 3 research questions that I focused on. And I wanted to focus on these questions because I wanted to understand not only, I guess, the perspective from patients, but also from healthcare professionals, but also to provide some recommendations to see how we can improve the experience of Black sickle cell patients across the UK. So initially, before the pandemic, I wanted to carry out primary research, and I wanted to speak to some of these patients and conduct semi-structured interviews. But as you know, life happened, and due to lockdown and ethical issues, I decided to move into conducting a scoping review. And so a scoping review is pretty much like what it says in the tin, really. It's me looking at other reviews in the UK to assess what research on sickle cell disease is actually out there, and almost create a summary of that review and to suggest themes that are common amongst Black sickle cell people across the UK. And I found that incredibly interesting. I think one of the first things that I discovered from that was just how little research there was out there. So I looked at around, I would say, somewhere between like 50 to 60 papers. And then I kind of excluded some because I had criteria. So, for example, I wanted to focus on Black adult patients. So I excluded papers that included pediatric patients because the care and the management of sickle cell disease would vary between a child and an adult. I also excluded patients who were part of patients who were included in research and they were from other countries, because again, I wanted to focus on the UK. I also excluded research that was written in other languages as well, because again, I wanted to focus on the UK. So I wanted to make sure that it was research that was based on the true experiences of patients and healthcare professionals in the UK. And that was important for me, given the fact that majority of sickle cell research out there is based in the States or in Africa. And as much as it's still helpful and it's still insightful on sickle cell disease and the condition, there are going to be differences based on geographical geographical regions, and our healthcare system in the UK is very much different to the model of that of the US and Africa, and understanding the implications of that. So that kind of links quite nicely actually to my next slide. So once I discovered my methodology and I realized that I was going to focus on those areas. So remember I said, understanding how effective care and pain management is for sickle cell patients, opinions of healthcare professionals and recommendations. I then had to think about, okay, what lens am I going to use to look at my research? And I focused on 3 areas. The first being the Commission of Social Determinants of Health Framework. And this was set up by the World Health Organization. It's actually built upon the rainbow model. And essentially what it's saying is, how can we assess the impact of healthcare, not just from an individual level, but also from a societal level? You know, how does macroeconomic policies and social policies and cultural values, how does that affect health outcomes? How does that create health inequalities? And how can we manipulate or change some of those things to give us a better outcome? So I was looking at various structural determinants of health as well. So social class, gender, ethnicity, all of these things are so important to understand, because the Commission of Social Determinants of Health Framework tells us that, you know, based on a person's socioeconomic position in society, that's going to have huge impacts on their healthcare. So, for example, somebody who is from a, you know, living in a council flat in Tower Hamlets is going to have a completely different experience from, you know, an upper income household in Chelsea, for example. And understanding how, you know, somebody's job and somebody's environment and somebody's mental health as well can affect their health outcomes is also important, especially when you look at sickle cell disease. You know, one of the things that I know personally from people I know and loved ones I know that have sickle cell disease is that, you know, they have to sometimes balance all of their responsibilities, and it can be quite difficult given the fact that, you know, you can sometimes be in hospital for long periods of time, unfortunately, when you're in a crisis, and it's unplanned, and that can easily affect their life, you know, with their friends, their social life. It can affect their work life as well. And I don't know, I mean, obviously I know that we're trying to make improvements when it comes to equality laws in the area of employment, but I do know that there's some jobs that they just wouldn't be able to accommodate that lifestyle, wouldn't be conducive to the well-being of that patient. So there's so many things that one needs to consider, and it's really scary as well, given the fact that when you think about our model in the UK, the fact that we have the NHS is great, but when you think about the fact that, you know, how is healthcare funded as a system, right? It's funded through our taxes, and the government, you know, has the power to create policies and healthcare agendas, and they're the ones that get to decide, you know, X amount goes to, I don't know, beds, and the other amount goes to medicines. And that can be quite scary because, you know, if they're not aware or if they're not considering certain diseases or certain health issues, then certain parts of the population can end up being demarginalized. And I think that's kind of what's happened with sickle cell disease, because it's not as common in the wider community. There's a lot of issues around healthcare and the delivery of health services. So Commission of Social Determinants of Health Framework was one of the key ones that I used to really have a look at that from, like I said, not just a societal level, but also from an individualistic level as well. The other frameworks that I considered was critical race theory and intersectionality theory. So critical race theory is it was a theory that kind of came after the civil rights movement. So in the 60s, you had Martin Luther King, and we had so many other influential people supporting that movement and fighting for, you know, the rights and equality for all. But then in the 70s and the 80s, people like Bell, you know, they started to complain that actually we're not really seeing any difference from now in the 60s. The civil rights movement was great, but has it done anything to practically support and positively influence or change the Black population in America and across the world? And they realized that actually, even if we look at it from various disciplines, so from sociology, history, medicine, all sorts of lenses, if we take all of those different areas, there still hasn't been much change. And I guess the proof is in the pudding. Like the fact they're called critical race theory shows that they're very critical of what's been done in the past. But they do this to say that actually we need a multidisciplinary approach. We need to consider all angles, and we need to think about, okay, if we want to look at how we can improve healthcare, we need to understand how the system is created. We need to understand that, you know, the healthcare system is actually a racist institution, not necessarily in terms of how, I guess, not necessarily in terms of how the government wants it to be or how we as the people want it to be, but when you look at how it's set up, when you look at, you know, the lack of diversity across healthcare, look at the lack of diversity across the leaders in the NHS, or the sort of education that's taught, or the diseases that are being taught at university and medical schools, is it actually conducive for the population that we have today, given the fact that, you know, we live in a United Kingdom that is full of, you know, various cultures and people from different backgrounds. So it's a really interesting theory. And the second one is intersectionality theory, and that talks about the fact that we have a synthesized identity. You know, I'm not just Doyin, a Black person. I'm a woman, I'm straight, I'm a Christian, I have various identities, and that makes me, you know, become one person. And I can be someone who can be oppressed by a multiple identity. So Kimberly Crenshaw, she was the one who coined this term in intersectionality. And the reason why she did is because she noticed that the Black woman in America was always left out of racist and feminist agendas. So she said, you know what, we've got the people over here, the Black men over here complaining about racism, and then we've got the women over here complaining about feminism. But if you're Black and a woman, then what happens to you? You get left out, or, you know, people don't recognize, you know, the implications of certain rules on you and how that might differentiate from a Black man or a white woman. And again, it's not just about race and gender, but it's also about class, religion, sexual orientation. There's all these other different forms of identity that make us who we are. And we don't live in this sort of isolated life. Like, I don't have one identity. So that's a really interesting one, because when you look at, for example, the concepts of, or I guess the stereotypes rather, of a Black woman, you know, a strong Black woman, we hear that all the time. A woman that can, you know, it doesn't look like they're in pain and they're fine. But then if you take that notion and you think about someone who's going through a sickle cell crisis, who happens to be a Black woman, and she needs, you know, morphine because she's in so much pain, and the doctors are looking at her saying, you're fine, you don't look like you need pain, based on their stereotypes that they may not realize they have, then that can be very detrimental to that Black woman. So that's just an example, of course, but there are various other examples that one can use to describe the impact of intersectionality theory in healthcare as well. Sorry, does someone want to say something? No? Okay. Okay, so moving on swiftly, because I do want there to be enough time for questions at the end. Oh, I'll just go back. So from my findings, after assessing the first research question, which looked at, you know, how do healthcare professionals view the care and pain management of Black sickle cell patients? So there was a report that was done in 2018 called an I'm in crisis report, and the results were quite astonishing. So I don't know if you can see the two charts on the right, but essentially it was talking about the fact that healthcare professionals are ill-equipped to support Black sickle cell patients. And why is that? Well, it's because they're not even being educated on sickle cell disease. And the ones that are, I mean, well, first of all, you've got 71.1% of nurses across 9 faculties across the UK that aren't even being taught on sickle cell disease.
Exactly.
And then out of the ones that are being taught, you know, you have literally less than a fifth of them being taught for longer than an hour, which is just crazy. But I think the thing that got to me the most was when I saw this comment. So I'm just going to quickly read the quote, but this nursing student from Greater London talks about the fact that she didn't learn anything from the university on sickle cell. It was all from, you know, her time on her placement and her own research. And I thought to myself, but you live in Greater London. Like, London is a cosmopolitan city. You know, there's so many Black people and there's so many people from different ethnic backgrounds in London, and you're going to go on to become a professional who perhaps may reside in London and work there. And the fact that you weren't taught that, I mean, if it wasn't for her own interest in sickle cell, would she have been able to support some of those patients, especially in, you know, serious conditions where they may end up in ICU? Because people don't realize that a crisis can escalate very quickly, and if the people around, who are usually the nurses, by the way, they're usually the first people who actually speak to a patient in a crisis situation. If they're not able to understand the signs and recognize what that patient needs in due time, then, you know, things can escalate quite quickly. And, you know, it's not even just about the patient, but it's also about the cost to the NHS. You might have someone who, if you had just given them the right medication, or if you had been checking on them in time, if you had given them, you know, extra oxygen, they would have recovered much quickly and then would not have to stay in a bed for, you know, 5, 6, 7 weeks, wasting money that could have been used to give to someone else if that healthcare professional was educated and was well equipped. So this is really important when you think about the magnitude of this problem. And then also, it's really interesting to also look at the patient's experiences as well. And I just quickly got a few quotes because I wanted you to understand it from their mouths and not from mine. But literally, the main themes that I uncovered when I looked at Black patients' experiences was their difficulty in describing the pain that they had. And the reason why that's so important is because it's usually them describing their pain to healthcare professionals that helps the healthcare professional provide them with a suitable treatment plan. And so describing their pain and just saying, you know, labour's a piece of cake in comparison to SCD pain, that sounds quite scary, actually. But I've never been in labour, so I wouldn't know. But for some of you who may be mothers on the call, or partners, partners to people who have given birth, you will know that that's quite a big thing to say and might be difficult to, how does one explain how severe that level of pain can be to a healthcare professional? Maybe perhaps a pain assessment indicator needs to be created, I don't know. But even that would be difficult to put together. And then the second theme there as well, like misconceptions and mistrust. You know, the patient, the doctor will look at you and he goes, I don't think that you're in a lot of pain. I mean, I couldn't imagine how that would feel, but, you know, already that would make a patient feel like, well, if I'm in hospital where I should be getting the support, where I should technically be getting better, and the person who's meant to look after me doesn't believe I'm in pain, and how am I really going to get through this difficult period in time? And, you know, maybe next time I shouldn't go to the hospital. And those sort of situations, those cases do occur. And then the last one, which I find super interesting, is role reversal. And I think this kind of links back to my point around education and healthcare professionals being well equipped. Because this person says, you explain to them, the doctors, like, but wait, you're the doctor, you're supposed to be telling me about my pain. And that, I think that was probably the strongest quote for me, because it made me feel like, oh my gosh, like imagine somebody's been to university for 5 years and had a vast years of experience, and you kind of see a doctor as a professional and someone who knows what they're doing, and to then think that you're in front of this person who should know how to help you and in fact doesn't, makes you even more vulnerable, especially because you're thinking, this is my last resort, like you're meant to help me, sir, or you're meant to help me, madam. So yeah, I think it's quite interesting to see that, you know, even in 2020, some of these experiences are still occurring. So my recommendations, and I guess some of the arguments that I brought up in my discussion section was the decolonizing of medical education. And that might sound like a strong term to many, but you know, as I said, I do believe that the medical education system is based upon one which really favors the wider Caucasian dominant group. And actually, there are so many ethnic subgroups in the UK who deserve to have their health interests met as well. And that needs to be amalgamated into the health agenda. And how do we do that? Well, we do that by showing medical students that, look, this is what sickle cell disease is, and this is what, you know, this particular disease looks like on an Asian person's skin, and just allowing people to have more experience and more access to patients of different backgrounds will enable the healthcare system to work more favorably to people of all backgrounds. And then also the idea of hidden illness, like, as I mentioned, there's still a lot of people that don't know about sickle cell disease. As I mentioned in the previous slide, you know, 71.1% out of those 197 nurses, you know, were not taught on sickle cell disease. And some of them may have been aware of it, but may not have had, you know, enough information. And even the lay population, you know, if we just step out of health, the healthcare system just for a second, like how many people actually know about sickle cell disease and the implications of it? Even within the Black community, how many people genuinely know how important it is, you know, to go and check, you know, do I carry the sickle cell trait? And, you know, if I meet someone tomorrow and I want to get married and we want to have children or we want to have a life together, you know, does that person have sickle cell trait? You know, could we potentially have a child with sickle cell disease? These are the kind of questions that we need to be asking ourselves and educating ourselves. And as I mentioned before, it's not even just within the Black community, because we do have people from other communities with sickle cell trait as well. So it's essential for everyone to go and get their blood tested. And when I say blood tested, it's not to know your blood type, because that's, you know, the O positive and A minus and all that. No, it's for you to know your hemoglobin type. That's what tells you whether you carry sickle cell trait or any other blood disorders. And last but not least, the medical charges and mental health. I met someone with sickle cell, and one of the things they said to me, Doyin, is, you know, every time I step into a hospital with a crisis, I know there's a 10% chance that I could die, and it's such a traumatic experience. And people always say to me, you know, how are you feeling? How's the pain? But nobody actually asks me, like, how am I? And nobody steps back to think, you know, how is the person? Because I'm a person before I'm a patient. And I thought that was such an interesting, you know, way to summarize and the experience. But also the fact that people don't even recognize the seriousness of the disease. You know, I guess another example is that, and this is not to compare the two, but just to kind of explain my point, is that if a young lady was raped and she, you know, was taken into hospital for medical examination, you know, that doctor will probably refer her to a counsellor and probably have her speak to someone to ensure that she's okay mentally. It's something that will probably have been done automatically. And yet someone who has sickle cell disease and may have been in a severe crisis and may be in the hospital for weeks at end, and then afterwards, when they're feeling better, be told to go home, but then maybe in a few months' time the same thing happens again. Why is it that doctors don't recognize that that could also be traumatic? And why are they not referred to therapists for cognitive behavioral therapy, and just to ensure that they're okay? These are the kind of questions that we should be asking. And also medical charges. We spoke earlier about the socio-economic position of individuals. If people from certain backgrounds are from a lower working class, but they're not on the payment exemption list and they're still expected to pay for medical charges, how are we helping them manage their disease during the course of their lifetime? And I actually argued that sickle cell disease is just as serious as diabetes and cancer. I mean, they're usually in ICU with those same patients, and yet people with those diseases don't have to pay for their medication, but sickle cell patients do. So that's an interesting one. Still don't quite understand why that's the case. And I know there's been several petitions to change that. But I think more needs to be done to get the NHS to really assess that and to see how they can support those individuals, because nobody should feel like they're deferred from receiving a decent health service or decent access to healthcare due to financial worries. So yeah, that's the end of my presentation. I hope that was useful, and if anyone's got any questions, then please fire away.
I've got lots of questions, Doyin. First of all, thank you for just taking the time to, first of all, go away and do the research and such comprehensively, and then come back and summarize it to someone like me, just, to get it. Now, I know about sickle cell and I have known that for a number of years. However, some of those points that you make, that how people are treated when they get into hospital, and the fact that there isn't enough due thought in how could they feel and their mental health, etc., etc. So it's, considering it's Black History Month, I think this is something that needs to be taken forward. And question to you is, are you aware of people who are lobbying, or, how do we lobby to change the thinking of government on this subject? Have you come across any sort of good examples? Because I think this is something that, people with a platform should be using to make more awareness of this situation and to really drive for change.
Yeah, I completely agree with you. I think for me, I think the main issue is just the lack of research. It's very difficult to say to the government that this is a policy we should recommend and this is the issue at hand, if you can't really have any substantial evidence to show that this is why you're making this argument. And so for me, I'm I'm encouraging anyone who's interested, right, to conduct research on health in different ethnic subgroups. It doesn't have to be in sickle cell disease, but I just think in general in the UK, there's a need for ethnic monitoring and collating of health data pertaining to ethnic populations. We don't seem to have a consistent database where we can measure healthcare outcomes in the ethnic community. So there needs to be research and data, I think, first to highlight those areas for concern. I think from there, we're then able to kind of, lobby the government or create systems, I guess, even if it's within our local communities, to educate ourselves and say, these are the things that we should be doing on an individual level, whilst also lobbying the government and saying, this is what we need to be doing on a societal level to ensure that these communities are no longer being demarginalized. I hope that answers your question.
Yeah, it does. And I think actually a great start is, Doyin, people need to be hearing more of this presentation in different places, because I think that creates awareness as well. So thank you. Superb job.
Thank you. Does anyone else have any questions?
Doyin, it's Karen. Thank you also for the presentation. Question for me is, I'm being optimistic here and a bit risky. Was there anything that you learned that was a pleasant surprise?
Yeah, there was actually. So I learned that they've recently started setting up haematology clinic centres across the UK, which is great, because what that means is that hospitals who do have experts in sickle cell disease and experts in haematology, they can train hospitals with staff who perhaps don't have as much, perhaps don't have confidence, or perhaps they haven't had exposure to patients with various blood disorders. So it's nice to know that that learning is happening, and that they're kind of transferring those skills and knowledges within the NHS as well to support the wider population as well. Another thing that I thought was really interesting is that there are also some people who, despite the fact knowing that they may not always experience, or may not always have the best experience, some people have said that actually they do feel safer in hospital, because it's that psychological thing of knowing that, oh, I'm in a place where I should feel better, and you know, I'm going to get the support I need and the attention I need, even if they don't always have, you know, I guess the best experience. They know that they're still going to have access to the medication and to the haematologist, and that kind of gives them a sort of a sense of relief. I'm trying to think, what else did I kind of come across I think that was it. I don't think there was anything, yeah, crazy. I think there was more, if I'm being honest, there was more negative surprises than positives. But I wouldn't say that it's all on the NHS. That's one thing I want to make clear. Like, I'm definitely not trying to bash the NHS. I'm just trying to say that overall as a society, the way it's set up, we are like full of racist institutions. And it doesn't mean that we can't change it. It just means we need to acknowledge it. And now that we've acknowledged it, what are we going to do about it? How are we going to ensure that, you know, there's more diversity across NHS boards? Because if there's more diversity across NHS boards, then we can ensure that there's people looking out for those ethnic subgroups, right? So yeah, and if perhaps, you know, society as well can do things from other points of view. So for example, understanding that, you know, certain diseases should be on the medical payment exemption list as well. You know, if the government can actually provide some funding towards that. There's other things that I think need to be taken into consideration. Like, it's not just an NHS issue, it's a society issue.
Thank you.
And I have a question. So first of all, thank you for breaking this down. Excellent dissertation, and also making people like me easily digest this quite intense information. I think, especially being a Black male, I feel as though that and a Black male who have friends, male and female, who suffer from sickle cell. I feel as though that even amongst the ethnics, we don't have a large enough awareness of sickle cell. So on the subject of intersectionality, and just purely from an awareness standpoint, because we see, for example, for STIs, gum clinics everywhere right now. I know there's obviously a major defund of the National Health Services, but is it your view that
I don't know if it's me, but
No, I think it's
Out for
Enoch,
me as
yeah.
well.
okay.
I'm,
Oh,
do you want
lost
to,
Enoch.
there, I stopped you sharing so that we can put more people up on there for you.
Yeah,
Is that
sure.
okay?
That's
Just so that
fine.
you get more faces to look at. Do we have Enoch back?
I think he might drop and rejoin, because I think, yeah. Oh, okay.
Is he back? We do have another question from Anthony that he wrote in the chat.
Okay.
Anthony, do you want to turn on your audio, or I can read it here while we wait for Enoch to join?
Yeah, sure. I think you can hear me there. There we go. Yeah, great presentation, Doyin. Just a quick question for, hang on a second. Just a quick question for my interest. Are there, I'll just repeat what I said in the chat, are there other major diseases that affect certain populations, so certain specific demographics, in a similar way to to sickle cell disease? And because I don't know, and are these similarly affecting diseases? Do they often receive more or less funding, attention, research than sickle cell disease? Just interested to see if it's a common trait across diseases, or is sickle cell a specific outlier?
Yeah, so there's another disease called thalassemia, which is quite similar to sickle cell, and it affects people from Mediterranean populations and Southern Europe as well. And similar to sickle cell, I mean, sometimes actually the two societies actually work together, but doesn't have as much funding or research. But then there are also some other major diseases like prostate cancer, for example, that affects quite a lot of Black men. I mean, in the UK, 1 in 8 men will probably get prostate cancer in their lifetime, but 1 in 4 Black men will. And again, more research needs to be done there to understand why that's the case. There's also certain type of diseases like triple negative breast cancer that affects a lot of Black women. And again, there's not enough research to understand why. So I think there are some that are probably a bit more popular. So I would say cancer is probably a bit more popular, but even then there's still a lack of research, and I don't know whether there's enough funding into particular subgroups, or whether it's just sort of a generic understanding of that disease, if that makes sense.
Yeah. No, it makes sense. Thank you.
No worries, thanks for the question.
Hello, Doyin, I've got a question.
Hi, go for it, Priska.
Yeah, so my question is more about what do you think can be done to change the perception of people giving blood, especially you mentioned earlier on about how cultural norms or religious norms can really change people's perception. So what myths do you think needs to be debusted by the community so that we can start donating blood more?
Ooh. That is an excellent question. What myths? I think, gosh, so I'm African by background, right? I mean, I was born in the UK, but my family are from Nigeria. And I know, speaking to other Nigerian, women, that they will say things like, oh, you can't give them your blood, they're gonna go and do witchcraft, or like juju on it. And I think it's a very sort of traditional way of thinking. I think the only way that you can combat such beliefs is literally through education. It's through sharing of stories. It's through saying like, look, this is what happens. This is the process. This is where your blood goes. There's no witch doctor that's coming to the hospital touching the blood. It's going from your body. It's being cleansed, and it's going directly to, the people that need it. And this is how it benefits their lives. This is how it extends their lifetime. I think hopefully through that there should be more understanding. What I would say is, obviously, I do respect everyone's religious views, and I know, for example, people like Jehovah's Witnesses, they just don't believe in that, and I think that's okay. If that's your religious belief and that's what you want to do, that's fine. But I think for people who are generally open to it, and they have nothing that's stopping them aside from some of these cultural myths, then it's literally listening to not only educating yourselves, but also listening to the people who are being affected by it, and understanding like, look, this is how your blood donation can really impact their lives. And it does nothing for you. It doesn't take away anything from you apart from an hour. But I think, that's something that I think we could all do if it meant someone could live for a few more years. So.
Thank you.
Hello.
Hi, Arlene.
If you can hear me. Hi there.
Yes.
My name is Arlene Wild, and I was diagnosed with sickle cell when I was 12 years old. So before 12, I didn't have any problems at all. And then basically when I was 12, I went on a school trip, got just had some water that wasn't very good, as I was living in Jamaica then, but not related to that, you know. And like children would, you got bad tummy or whatever, except that mine didn't get better. I just got worse and worse. And I started to lose a lot of weight. And even after they got rid of that, and I started to have the pains, etc. Anyway, to cut a long story short, I was diagnosed at that time. Then I came to the UK in my 20s. And the first thing I think that triggered it off was the cold weather. So I'm very vulnerable in the winter. Basically, between January and March, I'm officially a prisoner in my own house, almost, because if I go outside, sometimes if I haven't opened the back door without having the right clothes on, it can trigger a crisis. My experience is that I would say you've nailed it. Because I have years when I don't have a crisis, and then sometimes I have lots of crises. So it's hard to tell you how many crises I have in a year, but let's just say I'm a frequent flyer. So I go in quite often. And unfortunately, the experiences that you've said are spot on. It is mentally very demanding. I mean, you can't imagine what the pain is like. It feels like, if you imagine somebody got a huge sheet of broken glass and they sort of shove that into your leg. And at the same time, they got like a hot piece of metal, because it's not one pain, it's many pains. And if you move even the slightest bit, your body demands oxygen. So therefore the pain is excruciating. It triggers up another pain, like a sort of pounding pain. So it is pretty bad. And if you imagine you're in that situation and you're in an ambulance telling the ambulance crew what to do, just try and imagine it. You're desperate, you're on fire, okay? So that's kind of been my experience. On a positive note, I'd say in the last year, I have seen some glimmers of hope. I obviously have a hematologist, and I regularly attend hematology clinics once every 6 months, or once every 3 months if I've had a crisis. My experience generally, well, I find that the hematologists are, like you said, they have some knowledge, but not enough knowledge. There's a lot of guesswork. There's a lot of asking you, what do you think this is? What do you think that is? And remember, it's not just the crisis. You have other problems in between. So you're tired, or sometimes you have pains that you can't explain. You know, I'm always in pain, basically. I'm always in low level pain. And they can't explain what it is. Some of it will be to do with damage to the bones, because when you have a crisis, it deprives you of oxygen. Therefore, over time, it will damage your bones, and it can damage your organs as well. Many sickle cell people will not die from sickle cell itself. They will die from organ failure or something else. And the most dangerous thing we face is this thing called acute chest syndrome. I don't know if you came across that in your travels. And that, especially with COVID right now, I mean, I was in shielding most of the year, and I'm still in shielding. I put myself back into shielding because that is deadly. And that is where basically the oxygen is deprived to your lungs. You basically got a crisis in the lungs, and that is potentially very fatal, very lethal. There is not a lot of as much research done on adult sickle cell. Most of it is done on children, I find, which is a bit of a pain. I find that I have done a lot of self-education myself and trying to talk to other sickle cell people. Now, on a positive note, and one other thing, the other thing is I actually do not have sickle cell SS, which is what the whole thing is. I actually have something called SC, which is not a trait. It is, which makes it even more difficult to explain. So I have the trait, plus I have hemoglobin type C. Now, if you have hemoglobin type C, it's not the best hemoglobin to have, okay? It's not very common. It's just unfortunate that I have both those things together. So I don't have crisis as often, but a lot of medical professionals will tell you, we don't have crisis at all. That's what they believe on paper, which is not true. Because even some people with traits can have a crisis, but it's even harder to be believed when you go in there. I mean, I've had all sorts where doctors look at me and say, well, you don't seem to be in that much pain. Because mentally you learn how to be tough. You have to learn how to be tough, because when you are having a crisis, you cannot cry. It's not a good idea, because it takes oxygen. Anything that takes oxygen, you can't do it, because it's gonna make that pain spike and you're gonna lose control. So your main, it's like, I think of myself being in fatigues, you know, when I've got it, and I'm like a little SAS person, and I'm gonna fight my way through it. You find that you fight your way through, and I don't know about other people's experiences, at the end of it, you break down in tears. Every time I come home, I cry, because I look in the mirror and I think, oh my God, I've got me back. I'm back. you know, because when you have it, it's like you don't exist because it's that bad. But on a positive note, last year, because I used to live in Royal Berkshire, I've recently moved up to Nottinghamshire. Royal Berkshire is not, it is diverse, but it's not that diverse. You know, it's outside of London. And it's interesting what you said about London, because I just always assumed that in London, you know, I wouldn't have all these problems trying to explain myself. I've never lived in London. I've always lived outside of London. I've never really lived in a high Black community area. But I was pleasantly surprised because they have started to do a survey. Last year, the NHS called me in, and specialists from Oxford, John Radcliffe Hospital, which is quite a recognized research hospital in the country, have started to look at us in terms of cell, what do you call it, cell therapy? No, that's not the words. You know what I mean. Where they're doing the therapy to with stem cells.
Yeah.
So they are including us now in the research. I don't know how widespread it is, but I know that I'm involved in it. And they also did a survey of how many people in different boroughs, which means like districts, for those of you in America or in different countries, to see how many people actually live in the community with sickle cell, because before they were telling me that it was believed that they all lived in London or Manchester or Birmingham, and there weren't really any in the counties, so there was no need really to invest. So that is a positive thing, and they do include me now in all their letters and communications. It's a small start, it's a small thing, but it's a positive thing, which I think is, you know, might make you feel a little bit more encouraged. So that's been my experience of it. In conclusion, I've just moved up to Nottinghamshire, which Nottingham Hospital, there's a large Black community there, and there's a whole department, a whole building dedicated to sickle cell care. So I'm hopeful, as I am not getting any younger, that hopefully I will get the care I feel I deserve, and I won't spend hours in pain begging for pain relief. And that's my situation. If it does become more complex, I'll get the attention I need. So I just thought I'd share that experience with you all, and hopefully, you know, it might help.
Yeah, no, thank you so much. And I really appreciate that, because that's a lot to share with people that you don't know. So thank you so much for sharing your experiences with us. And it is really encouraging. And I hope people don't think that I sound so pessimistic. I don't.
No, you don't. No, you don't.
I don't. I am seeing positive changes, but I think that we can definitely, you know, pick it up a bit and definitely see more changes happening more quickly, because
and it is tough.
For too long.
Yeah, it is tough for sickle patients. I mean, don't get me wrong. I can't say that I've found it easy, because it's very difficult when you're ill, you know, when you're in pain. You want sometimes you're just not believed because you have no swelling, you have no temperature, you've got nothing. They're looking at you thinking, well, I don't get it, you know, and it's very, very hard. And so I don't think in any way, I think it's a very serious matter. And as you said, it can escalate, and mine has at times. And you're lying there and you're at the mercy of these people who some of them have no idea, and they genuinely don't. They want to help you, but they don't know what to do. So it is a very, very serious matter. Indeed, I think it is.
Yeah, thanks for sharing, Arlene.
That's all right.
Enoch, I've just seen you've come back. I don't know if you still want to finish your question quickly, and then we might have to end it there because I know we've gone over time. Sorry, Jen.
Yeah, thank you. My network dropped, so I had to restart my computer. But so I did want to finish off that question, and it was really to say, is it your view that where there are ethnic minorities properly densilated and people live who have the sickle cell, do you also find that there's awareness in how they can get tested? And my other question also is, because of what Eileen just mentioned, I know primarily your research was UK based. Do you know of any other European countries that maybe outpace the UK in care for sickle patients, or any other country, in fact, that have better care in their healthcare system than the UK?
Oof, okay, so to answer your first question about awareness of testing, I would say, if I'm being honest, it's pretty poor. I don't think, sorry, I'm just getting my charger before my laptop dies on me. I don't think there is much awareness on testing. And that's why I said it's kind of sad, because, you know, people kind of grow up, as I mentioned, and this is not to say, by the way, that people should or shouldn't choose whoever they want to be with based on the trait, but I think everyone deserves to be educated and understand that this is the implications of whatever decision they make. And so I think it's important for yourself and for your partner. Both of you should know that this is the case, and look, I have sickle cell trait and you don't have sickle cell trait, and this is what it could mean if we both had it. I think that's important. Is there awareness of testing? No, I would say there's more awareness on newborn screen genetic programming, which is great if, you know, if you have a child. But I mean, I think at that point it's too late, because you've already had the child, and if the child now has sickle cell disease, then I don't know, like, I just think it's better to be informed in advance, and for everyone to know that actually I need to do a hemoglobin test and know what my molecules, what my molecule type is, and not just say, you know, I think someone in my family has it, my uncle had it, I don't know. I just think we've come too far to just assume, or just to kind of go on a whim. But yeah, there needs to be more awareness of testing, to answer your question. And then to your second point around the European countries, to be honest with you, because my research was primarily on the UK, I didn't, you know, focus too much on that, but I did see some papers where there were some studies done in France, because I know France has huge populations of African Caribbean people from within France as well. But I didn't spend too much time there, so I can't, you know, tell you now offhand whether there's their healthcare or the delivery of their healthcare services is better than the UK. I did notice a lot of research from the States, but then I wouldn't necessarily say the States is better either, because their model is different. You got to remember that they get their healthcare system through insurance based on where they work, or if they pay for it, or a direct fee system. And what that means is that if you do not work, or if your health insurance does not cover a certain disease, then you are not going to go to the hospital and get the treatment or the healthcare service that you need. And so I believe that there is vast amounts of people in the US right now who are in need of healthcare services and don't have access to it. So I wouldn't necessarily say that the statistics from America are something that we could compare to in the UK, because in the UK, we have a model where everybody has access, or as long as you're a UK citizen, that is, you have access to free healthcare. So, and that's another reason why I could never bash the NHS, because I think that is a beautiful thing in itself. So I don't know if that answers your question, but it's just very hard to compare the two. They're just very different.
No, that's fair. Thank you for that. And again, thank you for this presentation.
Thanks, Enoch. So Jen, I think that's it.
I think we might have time for one more quick question.
Okay, cool.
And while we're holding a little bit of space, I just want to say, Doyin, that was absolutely excellent. And yeah, I just really loved the way you brought it all together, and your explanation of critical race theory and intersectionality was brilliant. I'm so glad we have it recorded. And, you know, I know that this has taken 2 years of your life to complete this MSc, and Kevin and I are really thrilled that you've finished, and we know that there's lots of people that have been supporting this, so please tell them thanks as well. So you should be really proud. And yeah, I just does anybody want to ask anything else? If there's any students on here, this was an excellent example of a really good piece of work. And I do think that if COVID and the racial justice activism that we've seen over the past few months has done anything, is at least I feel like we're having more conversations about the processes of structural racism, which I think your work really clearly shows that. And I think that it is a moment for people to kind of keep that conversation going. And those are tricky conversations for us to have, but you know, but it's the important work that we need to do. So it's great. Thank you.
Oh, thank you. Thank you for letting me do this as well.
As a thank you for coming, I have a couple of books that I would love to send you a gift as a book, a copy of a book that I've really enjoyed in my career. And so if it's okay, I'll get your address and send you a copy of that book. And I also have a copy, not a copy, I have a radical tea towel, which is of Maya Angelou saying, "Still like air, I'll rise." And so I'd like to send that to you as well, because yeah, in honor of everything. So thank you so much, Doyin, and we can just have a small round of applause for you on Zoom. So thanks.
Thank you, everyone. Much appreciated.
That was great. Take care, everyone else who's on the line on Zoom. We have another presentation at 4 o'clock. If anybody wants to come back, we've got another student presenting as well. Natasha Mutebi on her project with youth in Hounslow. So thank you very much. Doyin, keep well. Everyone else, keep safe and healthy.
Thank you.
Thank you, everyone.
Cheers, everyone. Thank you, Doyin.
Thank
Do you want to
you.
stay
Thank
on for
you.
just a second, Doyin, and have a chat
Okay.
with Kevin and I?
Sure, yeah.
Well done.
Thanks, Kevin.
Well, how far you've come.
I know, it's really scary when I think about
You sound like an expert, and I think yeah, you need to take this research forward. You need to.
I really want to.
Jen, can you stop recording this now?
Sorry, I'm sorry.